So our third talk is actually a little bit different this year, and is something that we're going to try out, and I think you're going to like it. We moved from someone from Poland to someone from Dublin, and not Ireland. This is the Dublin of Dublin Jerome High School. Brian Hansen, who's really one of our stars at Ohio State, is not a faculty member. Brian trained at Dublin Jerome and then at Ohio State University as an undergraduate, where he joined the laboratory of Vadim Fedorov, who's, I think, in the audience somewhere. He's actually from Russia, so a little bit further from Dublin. Brian, you'll see, has an expertise that goes far beyond a lot of faculty at most places. So in the last couple of years, Brian's published 17 journal articles in places like Circulation and Circulation Research. He's gone around the world to talk a little bit about the work that they do in their group here. And I think one of the very exciting things that Brian is going to tell you a little bit about is how Brian and Vadim and the team here at Ohio State has really established OSU and Columbus as the place to go for human heart research. So a lot of what Brian talked about in his speech was what they're doing with these donor hearts. Well, the hearts that go for research normally have been going to a pathologist and then going into a freezer somewhere. And for us as researchers, it breaks our hearts, right? So a lot of the research that we do comes from things like mouse models or rat models. But what if we could use human hearts to understand human disease? What if we could use human hearts to treat human disease? And that's what Brian's going to tell you a little bit about today.
Thank you very much, Dr. Muller. Like Dr. Muller just said, I'm an MD PhD student, which means I'm being trained in medicine and research. And it's a long 8-year program, but I'm very committed because I fell in love with cardiovascular research as an undergraduate here at OSU 5 years ago when I joined the lab of Dr. Vadim Fedorov and saw a human heart beating for the first time outside the body. And like Dr. Muller just said, to study human diseases, you really need to study the human heart. You can gain some information from animal models or single-cell studies, but the human heart is really the pinnacle of human disease research. And in Ohio State, we have the unique opportunity to receive these human hearts from the extensive transplant program here at Ohio State. When someone gets a new heart, we'll get their old heart. Or, like Dr. Whitson just said, some donor hearts aren't used for transplant, and we may get this heart instead. We are on call 24/7, just like the surgeons and the patients for these transplants. I go to the operating room to pick up these hearts. We then bring it back to Ohio State, and there's 20 different labs that each get a little part of the heart for their studies. In the Fedorov Lab, we get the atrium or the top 2 chambers of the heart up here. We're able then to bring the atrium into our lab and hook it up to our specialized system, very much like Dr. Whitson said, ex vivo perfusion of the heart. And when we're able to warm it up to body conditions, the heart is able to beat spontaneously. And this is because there's a specialized group of cells in the heart that generate a signal that tells the heart to beat. It's a little known fact that the brain only tells the heart to go faster or slower. Everything that the heart needs to beat is in the heart itself. So back in our lab, we're able to resuscitate these hearts. Here you can see a heart beating. And this heart is beating at a very normal rate, about 60 beats per minute, and that's very normal. If this patient would have had an arrhythmia or an irregular heartbeat, we would have also been able to reproduce that in our lab and have studied that irregular heartbeat. We study these irregular heartbeats by looking at the electrical properties of the heart, and we do that with a very unique technique called optical mapping. Optical mapping is when we perfuse a dye first discovered in jellyfish that changes colors when the electrical signal activates the dye. And we're able to see then this electrical signal at a much higher resolution and in much more detail than is possible in patients. Here in this movie is an optical map from a normal patient, and you'll see the electrical signal in red. It starts in the sinoatrial node, that group of cells, and then spreads in the right atrium and then the left atrium. And this, again, is very normal rhythm, but if the patient had an abnormal rhythm, we would be able to see that as well. This This shows us the electrical function of the heart. And like Dr. Zariba mentioned, the best way to study heart disease is to match up that function with the structure of the heart. And we also use cardiac MRI. And when the heart is outside the chest, we're able to get a much higher resolution and a much higher detail to see the structure of the heart in 3D and how this structure affects the function of the heart. We study arrhythmias or irregular heartbeats in the heart, either that are too slow, and this may be known as sinoatrial node dysfunction, or heart rates that are too fast, which could be known as atrial fibrillation. To start in our study, we do sinus node dysfunction. The sinoatrial node, again, is the leading pacemaker of the heart, and when something goes wrong with the sinoatrial node, the heart either beats too slowly or there may be long pauses of cardiac arrest. Both severely affect the quality of life of patients. The only treatment for sinoatrial node dysfunction is an implantable pacemaker. And this only acts as a crutch to keep the heart beating, but it doesn't heal the underlying problem with the heart. And there's many problems with these pacemakers to affect quality of life. You'd really want to fix the heart instead of adding a pacemaker. Recently, in the Fedorov Lab, we discovered that the human sinoatrial node is composed of multiple intranodal pacemakers that act as batteries to generate the signal, as well as multiple conduction pathways that act as wires to communicate the signal from the sinoatrial node to the atria. And with this knowledge, we're now working with clinicians here at Ohio State to see how can we diagnose sinoatrial node dysfunction as either a problem of the batteries or of the wires. And with this information, then we can move forward and see how can we treat patients in a very patient-specific manner. Do we need to repair one of the wires, or do we need to replace one of the batteries? And this could revolutionize the treatment of sinoatrial node dysfunction. The other arrhythmia that we study is when the heart is beating too quickly, and this is called atrial fibrillation. It's the most prevalent arrhythmia in the United States, and you can see it gets more prevalent with age, and with people 85 years or older is up to 10% of the population. And it's the leading cause of stroke, which makes it so dangerous. Atrial fibrillation causes stroke because the atrial muscle isn't contracting in unison, the blood doesn't flow smoothly, and because of this, the blood could clot. It doesn't contract in unison because there's a very chaotic electrical activity underlying this chaos. But at Ohio State, instead of just seeing chaos, we're looking through the chaos to try to see if there's organizing centers that are driving the rest of the arrhythmia. And recently we showed in our lab that there may be atrial fibrillation drivers hidden in the patient's chaos that could be targeted with an ablation procedure, which is where a catheter is introduced through the vein and a small part of the tissue is burnt to disrupt these drivers. Here we can see a driver may look like a circuit or a circle, and if you cut that circle, it can no longer spin around this area, and you then cure the arrhythmia. But it's very difficult to find these drivers within the chaos of the atria. And so we're working side by side with clinicians here to improve the clinical techniques of not only finding these drivers, but how to minimize the amount of tissue that needs to be burned to treat arrhythmias. Currently, to find these drivers in patients, they use a technique called a basket catheter. Again, it's introduced through the vein of the leg and is expanded inside the atrium. And it's able to record electrical signals from about 64 points in the heart. But with only 64 points, it may be hard to interpret these maps, because again, we're looking for a very sustained circuit moving in a circle, and I can't even tell you where exactly that would be in this patient. But because we study human hearts outside the body, we're able to take the exact same clinical technique and integrate it with our optical mapping, which allows us to improve upon the technique. So with our optical mapping, then instead of having 64 points of reference, it has 40,000 signals. We can see a very clear rotating driver in the heart. And again, if we just disrupt this driver, we may be able to cure a patient's arrhythmia. we are also looking into how structure affects these drivers. And with MRI, we're able to see that there's a very unique set of muscular bundles that create these circular circuits. And we're now working with Dr. Hummel and Dr. Simonetti to start a small clinical trial where patients will be recruited. They will get MRI of their heart first, and then we'll see if the MRI can identify their driver and help clinicians to identify them and target them for treatment. And I'm very humbled to be at the cutting edge of research here at Ohio State, working alongside both basic scientists like Dr. Fedorov and Dr. Moeller, as well as clinicians like Dr. Whitson, Zariba, and Dr. Hummel. And maybe in 5 years, when I graduate, I'll be using these techniques that we develop here at OSU to treat my future patients. Thank you.